I've had women call me on the way home and say that they went over a speed bump and they're worried that something happened. And I'm like, I promise it is not, or they sneezed.
Hello, everyone. Welcome back. We are talking about IVF cycles today, which is one of my faves. And Dr. Nichols here came dressed appropriately for the topic.
So I have to be able to tell you where I got it. So I did get it from Etsy. I'll tell you where, but I have my nice headband. It is IVF. It has sperm and eggs and petri dishes.
And a uterus.
Yes, the Craftosaur made it for me. I'm crafty. I do a lot of crafty things, but sewing is not one of them.
Perfect. It's perfect. And how on brand and on topic today. So we're just going to walk through an IVF cycle so that you kind of just have a sense of what to expect. It can be very overwhelming and scary. And, I've been through it, a few times now. And it's a lot. It's a lot emotionally, it's a lot physically, but I think that if you know what to expect, it can be a little bit less scary. So from a doctor's point of view, and then from someone who's been through it, we can kind of talk a little bit about it and know that if you're doing reciprocal IVF or if you're doing IVF, that it's the same thing. It's just going to be happening with one uterus and then the other.
Yeah. And I think one thing I'll tell patients is, I have never had a patient go through it and then retrospectively say that it was like worse than what they thought it was. Like, I think people build it up in their minds of what they think it's going to be. And afterwards they're like, oh, that wasn't that bad.
Especially when you have a baby. I mean, it's like, especially when it works. And then you go through childbirth and you're like, oh yeah, that was nothing.
You hear about it and you think, oh my gosh, the medicines, or oh, this or that. And I tell people, we talk you through, we take you step by step, we give you little bites of it. And then we say, okay, then we're seeing you back. And then we're seeing you back. And you just kind of like go through it. And then you're like, oh, I did it. I made it through and I'm okay. So what is IVF, or in vitro fertilization? And it's the idea of like the petri dish baby. But IVF originally was created for women with blocked tubes. In 1978, the first IVF occurred and has come a long way. It is much further than where it was at that point in time, but it's commonly used. It is a common term. It is a common procedure. And I think everyone knows about it now. But I think it still has this connotation of like, oh my gosh, what is it? I need IVF. And, hopefully as you get to that point, your doctor can kind of talk to you about it and help explain that. IVF in general, I'm pulling the uterus model into the picture again. Ta-da. IVF in general is the idea that we can give a woman injection medicines to help her ovaries make eggs. Usually she's on those injection medicines for about 9 to 12 days. And during that point in time, we do ultrasounds and blood work to watch as as her ovaries form those follicles with the microscopic little eggs in them. So we do ultrasounds and blood work to watch as they're forming. Why? Because depending how they're forming, if the hormones are the estrogen is going up significantly, we bump the dose down. If it's not going up enough, we bump the dose up. And if it's doing just perfectly, we kind of keep the dose right where it is. And so we watch closely. At the end of that time, as the ovaries look good and have hopefully a good number of eggs and the hormones look good, then she's done with the medicines and she undergoes an egg retrieval. At egg retrieval, she's sedated, doesn't feel a thing, and the ultrasound probe goes in through the vagina. The needle pokes right through the vagina, kind of back behind the uterus and into the ovary. The procedure usually takes about 10-15 minutes. And what we do is the needle pokes into the ovary and drains the fluid from the follicles, capturing the microscopic egg. We don't always get an egg from every follicle. Usually the mature follicles have an egg in them that releases from the sidewall. Some of the smaller follicles don't always have a mature egg that releases, but we try to get eggs out of every follicle we can. And the tubes that we get go off to the lab and they count the eggs. So egg retrieval, we let women know how many eggs we get. The same day we get partner sperm or donor sperm, and the sperm and the eggs are mixed. So uterus model done. So we have the eggs in the dish, we take the sperm and we either lay the sperm on top of the egg, which is conventional fertilization, or which you would expect with donor sperm, that the sperm would be good and we could do conventional and just lay the sperm on top. Or if for some reason the sperm is lower, doesn't look good, we would do something called ICSI, intracytoplasmic sperm injection, where we would inject a sperm into every egg. And then the next day, the couple in our practice gets an email. I'm sure some practices would get a phone call, but you get an email or a phone call letting you know how many fertilized. I tell couples, don't expect them all the eggs to be mature. Don't expect them all to fertilize. So I tell people, hey, I only have 10 fingers. So let's just assume you get 10 eggs out. You may have more, you may have less based on age, based on how you stimulate. But if you get 10 eggs out, let's just say 8 of those eggs are mature. And out of those 8 eggs, and this is if you do ICSI, we know how many are mature. You may not know how many are mature necessarily if you don't clean them off, do the ICSI, but you may get an email the next day saying, okay, 6 of them fertilize. And that's normal. We know they aren't all going to fertilize. We know they aren't all going to grow and divide. But of those, if we say, great, 6 fertilize, we're going to watch them grow and divide. And let's say of those, 5 are growing and dividing and they look great. And at this time, we continue to watch them grow and divide and watch them progress until the blastocyst stage. So they start out how many fertilize, and then they become 2 cells, and then 4 cells, and then 8 cells. And then by day 5, they're hopefully what we call a blastocyst. And a blastocyst is hundreds of cells within that embryo. And that's the stage where we transfer that embryo. Now, there's a few different things that can happen depending at this stage. We have the capability of taking cells out of embryos and sending those cells off for genetic testing, something called pre-implantation genetic testing. Not everyone needs this, depending on the age of the woman, depending on if she has risk of genetic diseases. So the most commonly known one is something like cystic fibrosis. If you're using donor sperm, even if you were a cystic fibrosis carrier, you can make sure that the donor sperm was not a cystic fibrosis carrier, so you could make sure that you weren't passing on the risk of that disease. If a woman had increased risk of miscarriage, sometimes this is done, although the data shows that it sometimes can be conflicting of whether it's beneficial or not. Advanced maternal age is sometimes a reason that this is beneficial. Why? Because, as a woman ages, there's an increased risk of not all of the embryos being normal. And so the benefit of genetic testing of those embryos to see which ones are abnormal or normal can increase the chance of pregnancy based on knowing whether that embryo is normal or not. So this is something that every doctor and every patient can be discussing of whether it's beneficial to consider pre-implantation genetic testing. If you're freezing the embryos, then clearly the woman's going to get a period, and then look at, are the embryos normal, or, did you freeze them for another reason? Sometimes you're freezing them until your partner can get her uterus ready or something else. And then prepping the uterus at a later time for a transfer. If you're getting the embryo put in during a fresh cycle, then the lining is already ready because we just got the eggs out and that lining is nice and thick, and we can just do a fresh transfer on that day 5.
Right. Or in our case,
that is a lot.
No, or in our case, we got my lining ready first, and then got the eggs out of Jordana.
So when you're doing reciprocal, we want to know that that lining of the other partner is entirely ready, so that it's not trailing behind and the eggs are ready. And then we say, oh, but the lining's not ready. So we get the lining ready of the uterus for the other partner. And we can kind of hold that in kind of a holding zone, and then start getting the ovaries ready. And then we say, okay, as soon as the eggs are ready to be retrieved, then we expose the uterus to progesterone so that the uterus thinks that the ovaries just ovulated. And we say, okay, now this uterus thinks it's just ovulated and it's ready. And then we can say, okay, now we're ready to do a transfer.
Perfect. And is there a benefit to a fresh transfer? versus?
So good question. And there's a lot of data out there saying kind of both sides. I would say that there's questions saying there's benefits to frozen transfer in relation to if your estrogen is extremely, extremely high, and there may be kind of a discordance in relation to your estrogen to progesterone. But then I'm going to also tell you that, if there's not that discordance and you're picking the absolute best embryo, there's probably just as good. And there just some recent data came out saying, hey, fresh transfer may be just as good. So, really it's the quality of the embryos. It's how a woman stimulates. And obviously, if you're doing the genetic testing, then any data is going to be beneficial, showing that if you have a chromosomally normal embryo, then you're going to have a higher chance of success because you're ruling out the abnormal embryos. But if you have a good stimulation and transfer a good quality embryo, your chance of success is good.
Right. And I mean, especially with like our situation doing reciprocal IVF, it's like, we already know my levels are what they're supposed to be. So if we could do that fresh transfer and not, I always thought it was like not put any extra stress on the embryo of having to be frozen and then thawed.
Yeah.
I don't know.
But the majority of embryos do remarkably well with a freeze and a thaw, but I still say, 95%, survive that, but not all of them.
Ours didn't. And then we were the one that, fortunately, but both of our kids were fresh transfers for us. So I just have a special place of belief in fresh transfers. Okay. So, then the transfer happens and, for me, I was on a lot of medication because I wasn't the one who ovulated or anything like that. So we have to kind of trick my body into thinking that I, did release an egg and all of that. So I'm on progesterone and estrogen and all of this stuff. And, so is that kind of like typical?
Yeah. One of my favorite sayings is the IVF meds are kind of like the fads of fashion, is they kind of go like this. And since I've been in fellowship, do you use injection progesterone? Do you use vaginal progesterone? And I mean, I even remember when I was a med student and doing a rotation at a program, there were studies being done of saying, hey, 3 times a day vaginal progesterone, is it okay? Is it not? And then, hey, no, you need to use IM progesterone. And I mean, since I've been at, my current practice, we've gone through waves of both. I think that, currently we have women who do both. We do what we call cryosynthetic. So it's a frozen cycle or just like you, where you're prepping because you haven't made an egg. Even if it is a fresh transfer, it's not really a frozen cycle, but you're prepping because we know we're using an egg or an embryo that wasn't from you, that you could do your own natural cycle. Now, we can't do your own natural because we can't count on the fact that your egg is going to release at the time where, your partners would at the same time. So we have to be able to have you on a medicine type cycle. And so in that case, we know that we want to be able to have you on an appropriate amount of medicine where you're not going to release your own egg. And so in the past, we have used just oral estrogen, and in the past, we've used estrogen orally and patches. And is there a right answer? No. Both have been proven to work, and it's just kind of a matter of kind of what the studies are showing at the time. The injection progesterone, the downfalls of it is it's a shot in the hiney, no question. It's not easy. You have to have someone else to give it to you. Yeah, it's not easy. You feel those lumps and those welts and you feel them later. The vaginal progesterone has its own downfalls too, and you're taking it multiple times a day and you notice that discharge. And so we tend to, if you're in your own natural cycle, use just the vaginal. If you're in just a medication type cycle, use the injection progesterone.
Got it. Yeah, it was, a lot, but again, worth it. That's, you kind of have to think about, kind of the end goal. And, once you go through labor and childbirth, it's like, that was nothing, all the meds and all of that. But yeah, so not.
And then I think the only other thing we didn't say was the transfer. When you do a transfer, kind of similar to whoever hasn't watched the insemination, but it's kind of similar to an insemination. It's just a smaller amount of fluid with a teeny little embryo. We put that embryo into the uterus, into a perfect little spot, lower than the fundus, the top of the uterine cavity. So below that uterine cavity, making sure not to go near the top of the fundus to not cause any cramping. We do it under ultrasound guidance, a little different than the insemination, so that we can watch by ultrasound as that catheter goes in, so we know we have it in the right location. When we're done, that catheter comes out, we hand it back to the lab to make sure that that embryo was not stubborn and didn't stick in the catheter, so that we know it is in the uterus, and then we're done. We like that a woman goes home and rests and relaxes that day, although she could probably run a marathon and probably do jumping jacks. And we know that embryo is not going anywhere. I tell women that uterus lining is kind of like two big fluffy pillows. It is not going to fall out. I've had women call me on the way home and say that they went over a speed bump and they're worried that something happened. And I'm like, I promise it is not, or they sneeze. It is not falling out. Women conceive naturally with a whole lot more than, women who undergo IVF. You understand, they just went through 9 to 12 days of, injection medicines, and unfortunately a whole lot of financial components sometimes. And, what is in their uterus right now is
it's an embryo. Like you already know that it's
valuable, and you're like, I want to protect it. But there are women out there who are running marathons and who are on roller coasters and doing crazy things and don't even know they're pregnant and not giving it a second thought. So we want it to be protected, but we say go home and rest and relax. We don't want a woman on bed rest. We don't want you not laying there not doing anything, because why? The hormone levels are high, your estrogen is high, and that can increase the risk in general of blood clots if you're laying there and not doing anything. So normal activity. But in general, we just keep our fingers and our toes and everything else crossed, and we do blood work, make sure everything looks good, and then we do the pregnancy test about a week and a half later.
Yeah, it's nice with IVF. You get to go 5 days earlier for your blood test because it's already a 5-day, usually 5-day-old embryo. So that was always a lovely perk of not having to wait as long. Well, that's IVF in a nutshell. Yeah. Well, thank you for your wisdom. And if anyone has questions, let us know.
Have a good day, everyone.